Our guest speaker today is Dr. Rendon Nelson, a Reed and Martha Rice Professor of Radiology and Vice Chair of Academic Affairs at Duke University. Welcome, Dr. Nelson.
Hi, good afternoon, Kristen. And I'd like to first of all thank the sponsors, Applied Radiology and Bracco, for allowing me to speak on this topic. You know, the topic of protocol development in CT is one that is it's both evolutionary and a bit humbling. Evolutionary in that it's one of those things where we learn a lot about what we do from day to day, and it allows us to make adjustments in protocols in an evolutionary fashion. But it's also humbling in that, although I like to think I have all the answers, when I read cases from day to day, I realize that we still don't have it all figured out and there's more to learn. So I'm going to share with you some of the things that we have learned over the years, and hopefully you'll find this helpful. Here's our first objective slide. Kristen alluded to some of these objectives. And basically what we're going to do is we're going to break down how we develop CT protocols one step at a time and really dive down and look at all the details and look at them individually relative to how the scanner works and the parameters relative to multi-detector CT scanning, relative to the contrast media in terms of the dose and the rate and the scan delay, saline chaser, and those kind of details. And we'll also look at relative to the radiation dose. There's some exciting new technology out there with power injectors, particularly related to software, and I'd like to discuss that as well and show how that can be helpful to your practice. So these are the main protocols we're going to talk about today. There's some other niche applications that we won't discuss. But in looking at the abdomen and pelvis, chest, abdomen and pelvis, dual liver, and dual pancreas, we'll again look at the parameters, including the detector configuration, the helical pitch, the gantry rotation time, and then the parameters of milliamperage and voltage. And then for contrast media dosing schemes, there's a number of them out there. We'll talk about what might work best in your practice, rate, timing, saline chaser, and then I'm going to share with you some research that we've done recently looking at reproducibility of particularly radiation doses, and we'll extrapolate that as well as contrast media utilization. So what to acquire and when always comes up when developing protocols. We don't really use the unenhanced CT very often. If you were to want to quantitate liver iron, obviously you would need an unenhanced CT to do that, although in our practice we use MR more for liver iron than we do for CT, but it's certainly an option. Obviously for renal stone disease or for biliary stone disease, it's better to have an unenhanced CT. The arterial phase is useful in patients with primary liver tumors, hepatocellular carcinoma, hepatocellular adenomas, and focal nodular hyperplasia, as well as in the pancreas. Now, it's a little bit different in the pancreas in that most tumors are hypovascular, so we're looking at the contrast between the tumor and the vividly enhanced pancreatic parenchyma. Furthermore, there are also hypervascular endocrine tumors, islet cell type varieties of tumors in the pancreas that will be basically elucidated with the same protocol. And then hypervascular metastases, wherever they occur, particularly in the liver, can also be well elucidated during the late hepatic arterial phase, and we'll go through the details for all of these. We won't specifically talk about CT angiography. It's one of those indications, however, where we may only acquire images during the arterial phase, which is somewhat unique. Most applications that we do include both an arterial and a venous phase, and the contrast media parameters are a little bit different when you're looking only at the arterial phase, and we'll talk about that. Almost all the protocols we'll discuss do have a venous phase, and that's pretty important. However, the equilibrium phase, which occurs when these small molecular weight extracellular contrast agents, they're exchanged between the intravascular and the extravascular component of the extracellular space. When that becomes equal, they're transferring at an equal rate. We call that the equilibrium phase. And although it may be a way to miss metastases in the liver, it's very good for looking at for washout of hepatocellular carcinoma. And actually the LIRADS classification system relies upon washout in determining what classification it receives. On the other hand, the more desmoplastic varieties of cholangiocarcinoma that have more fibrous tissue in them naturally, they tend to retain contrast material as fibrous tissue does in general. And as a result, about a third of them will have delayed washout and will be hyper-enhancing relative to the hepatic parenchyma. And then the excretory phase, which we won't discuss further today, is really mostly used for transitional cell or urothelial type tumors. All right, let's dive down into the CT of the abdomen. It's a simple protocol. And on the bottom of the slide, you can see the injector parameters, and on the top, the scanner parameters. And on the x-axis is the timing. So first of all, we start with the injection, which includes a bolus of contrast material. And our boluses are typically customized according to the size of the patient. And there's a number of ways to do that, which we'll discuss. And the rate is typically given over a selected period of time, typically on the order of 30 to 40 seconds in duration. So in other words, we take the volume, we divide it by the number of seconds of duration, and that determines our rate. Then we use some kind of a automated timing where we monitor the injection protocol and determine the scan delay by that. And notice that it starts at about 15 seconds. For a simple abdomen and pelvis, we monitor the liver parenchyma with typically a 1 or 2 relatively good size regions of interest and looking for a threshold in the order of 50 to 75 Hounsfield units. You know, I started at 50 years ago. I'm beginning to think that a 75 Hounsfield unit threshold may be a little better. It actually changes fairly rapidly, so the timing is not quite as critical. But in the era of fast scanning, it probably makes a little more sense to start later since the acquisition is so quick. So once that reaches that 75 Hounsfield unit threshold, then we manually trigger the exam. And about 40 seconds later, we start the venous phase. That's actually a misprint. That should be about 12 seconds later for the non-cirrhotic patient and 15 to 18 seconds for the cirrhotic patient for that scan. And then we simply do an abdomen for that through the iliac crest during a single breath hold, which is on the order of 2 or 3 seconds for most multi-detector scanners. The acquisition parameters for the multi-detector scanner, as most of you are probably using 64 slice scanners at the 0.6 or 0.625 millimeter detector configuration. There are different pitch options. Generally, we don't like to go too much below 1, but there are options to go up to 1.4. The slower pitches, as I'll discuss later, have the option of giving a little better data set because of oversampling. However, the 1.4 larger pitch has the advantage of a shorter breath hold time, so that might be advantageous in some patients. Generally, we start with a 0.5 second gantry rotation time, and then I allow our technologists to inch it up to 0.6 or 0.7 in the case of larger patients, keeping in mind that you do increase the dose substantially by doing that. Most patients we scan at 120 kVp, although in smaller patients you can use 100 kVp. I wouldn't recommend 80 kVp in adults in general. It's just too low from some phantom studies that we looked at, although it might be a reasonable selection in children. And then we do current modulation in both the X, Y, and Z axis, and we'll talk about each one of these parameters. Let's step back now and look at the contrast media parameters. Remember, for the abdomen, we only are evaluating the abdomen during the venous phase, and the timing is actually determined by the rate of injection, although the bolus doesn't change that much, and peak iodine is determined by the total iodine dose. And it looks like this. Here we can see that the injection rate determines the timing, whereas the peak injection is determined by the iodine dose. And the analogy I would give to this is if you have a headache and you're used to taking 200 milligrams or 400 or 600 milligrams of Motrin, if you were somehow able to come up with a type of medicine that would get into your bloodstream a lot quicker, but you only took 200 milligrams, it would have a much quicker action, but it still wouldn't take your headache away because it's not enough dose. So for venous phase imaging, faster injection rates are not going to get you to the dose that you need to get adequate enhancement. And that's why dropping the dose when you have venous phase imaging is not a good idea. And you cannot really save contrast media during the venous phase, not adequately, and keep up your efficacy. If you do increase the dose, for example, from 100 mLs to 150 mLs, you can see that the timing, if given at the same injection rate, simply gives you a higher peak enhancement. And you can generally look at scans and tell kind of what contrast media dose was given by looking at the level of enhancement of the vessels and the liver and the pancreas and the kidneys and the spleen enhancement pattern. So generally higher with higher doses. Now, what about the dose? You know, in our practice, we use kind of a sliding scale. For years, we used a fixed dose, where everyone got about the same contrast media dose, and something on the order of 40 to 45 grams of iodine. Another scheme is to use a weight-based dose, where basically you give so many grams of iodine per kilogram. Studies have shown that this is a little bit better than using a fixed dose, but not substantially better. And there's a good reason for that, and that's because although fat may be substantial in some patients, fat doesn't really get that much blood flow relative to the volume of tissue. So as a result of that, most of the contrast media that we get goes to our lean body tissue. So it's a simple way of doing it, but it's not terribly effective. Habitus-based schemes, however, are probably the way to go. You can use BMI, there's some schemes for that. You can use body surface area, there's some schemes for that. Although these require more work and more input from a technologist or for a nurse. So I think until we have more automated way of doing these, it's probably something that's a few years away, although certainly more desirable. I'll show you some data on that. Actually, measuring the lean body weight from a preliminary simple single axial CT scan is a very effective way, as I'll show you, as lean body weight seems to be the best way to do it. In the meantime, however, what I would suggest is this simple approach, that if you have most patients in the order of 100 to 300 pounds, and that's a very wide range, give them something on the order of 45 grams of iodine. For smaller patients, less than 100 pounds, you could drop the dose down to 30 grams, and for larger patients, you could go up to 60 grams of iodine. Again, these are some guidelines. You might not want to make such a drastic change for the various groups, but it is a simple way of giving you some guidelines or some kind of a sliding scale to determine the contrast media dose, above and beyond weighing the patient, doing some BMI calculations, etc. Let me just share with you some data from a study we did a few years ago where we compared 4 different groups of patients. And we had a fixed dose in 25 patients, one dose determined by total body weight and another 25, a calculated lean body weight basically from the BMI, and then measured lean body weight where we actually use these scales that send an electrical current up one leg and measures how long it takes to come back down the other leg. The more fat you have, the longer it takes. The less fat you have, the shorter it takes. How it works. And here's the data basically. If you look at the 4 groups, notice that what we wanted was the most reproducibility. So you can see that the standard and the total body weight had a wide range of different doses, as did the calculated lean body weight. Although if you exclude that one outlier, it was a little bit tighter. But the measured lean body weight did seem to have the best reproducibility in the study, suggesting that's probably the way to go in the future for determining the dose of contrast media. And this was statistically significant. Let me show you an example. Here's 2 different patients, patient A and patient B. They're clearly very different in body habitus. One patient weighs 46 kilograms, the other 99 kilograms. You can see that the BMI is basically twice it is in patient B than it is in patient A. Their lean body weight, however, from a single axial slice to the pelvis wasn't that different, 42 kilograms in one and 53 in the other. If you base the iodine dose on their total body weight, you can see that it's almost over a dose of 2.14 times As a matter of fact, that would be an awful large dose, 212 mLs. I don't know that any one of us would be comfortable giving that much contrast media. On the other hand, if you factor in the difference based on lean body weight, it goes up to 159, which is only a 1.26 times the dose. So it looks like this is an effective way to give contrast media, and certainly is the focus of a lot of research. All right, let's talk about a little bit about rate. As I mentioned, generally we use rates on the order of 3 to 5 mLs per second. If you get down to 2 mLs per second, you can generally tell by looking at these scans that they are a little less enhanced compared to those at 3 mLs per second. And generally, if you want to figure out a good rate, then you simply take how long you want to administer that contrast material, typically 30 to 40 seconds, and you divide that into the volume, and that'll tell you that it should be given at a certain rate. For instance, if you have a 120 ml dose you want to give, over 30 seconds, that'd be 4 mLs per second, or over 40 seconds, that would be 3 mLs per second. I have to say, I don't really have a lot of experience using a variable rate. I think it's complicated. I'm not convinced that it's advantageous to do that. The scanners the power injectors are clearly capable of doing complicated variable injection rates, but I'm not really convinced that it's worth all the extra trouble and adding to the complexity of the examination. All right, so let's look at this for example. There's different ways to do the scan delay. You can use a fixed scan delay, although in 2013 I wouldn't recommend doing that because it's a bit antiquated. And there's good tools out there. All the scanners now allow other techniques. One of them is a timing bolus, where you take about 10% of the dose, for instance, 15 mLs rather than 150, and you give it at the injection rate you intend to give the contrast media, and then you monitor the contrast enhancement, say of the aorta or the liver, and you determine what that delay should be. And you use that explicitly in your scan delay. I'm not as favorable about this technique, mostly because it uses about 10% of the contrast material for non-diagnostic purposes, and it also takes a little additional time and effort. I think that automated triggering is fairly mature on the existing scanners being around for many years, and for the abdomen and pelvis, as I mentioned earlier, we start at about 15 seconds and we monitor the liver until we get to a certain parenchymal enhancement level, typically in the order of 50 to 75 Hounsfield units. A little bit about oral contrast media. You know, it's been interesting to watch that development over the years, whereas almost everyone got oral contrast material, either in the form of very dilute iodine or very dilute barium in the past. Now we see a much lower percentage of patients receiving oral contrast material. It kind of started in the emergency department where the physician said, you know what, we're just tired of waiting for our patients to go to radiology and sit there and drink for 45 minutes. It's really killing our turnaround times. So we were attempting to be open-minded, so we allowed them to order the scans without oral contrast material. And in the era of fast scanning, we became more comfortable with those scans. I'm not sure it's always the right thing to do, but I will say that I'm more comfortable doing it now than I was in the past, particularly for trauma cases. I will also say that we do use it routinely for inpatients, particularly in those patients that are for abscess surges, because fluid-filled loops of bowel can look very much like a multilocular abscess, and I've seen that be a problem before, so be careful with that. We do give the patients water once they're on the table, and in some patients we give them water only, particularly for patients evaluated for pancreatic adenocarcinoma, where we want to be able to see the lumen of the duodenum and the proximal jejunum well delineated by the low-density water. Here's a curved planar reformation through the main pancreatic duct. We also use volumen, which is a very dilute barium solution, which is so dilute it looks like it's basically water density, particularly for evaluating the small bowel. Here's a small bowel protocol. It's the vivid enhancement of the wall through the contrast media bolus and then low density contents within the bowel lumen. But as I mentioned, a large percentage of our patients, and a growing percent, get no oral contrast material at all. All right, let's talk about the CT parameters. First of all, I would really recommend, if you're using a 64-slice scanner, that you do so with isotropic voxels in every case. I see a lot of coronal images come from the outside, and I think they're probably reconstructed with either 1.25 or 2.5 millimeter thick axial slices, and you can tell the difference. They're not near as sharp and they don't have as much diagnostic capability. So other than the impact on your archive system for the number of slices that are generated, they will look sharper if you can acquire them isotropically and then use those isotropic axial slices reconstructed at 0.625 millimeters and use those to form your coronal reconstructions. Now, the coronal reconstructions are not isotropic themselves in that we use 3 millimeter thick slices in the z-axis, and that's what we do to get the noise down, because they look noisy in the axial plane, but they don't look noisy in the coronal plane simply because they're non-isotropic in the coronal plane. And we did an experiment a few years ago where we reconstructed coronals at 1 millimeter, 2 millimeters, 3 millimeters, 4, and 5, and the reviewers, a wide variety of reviewers, settled on somewhere between 2 and 3 millimeters, and that's why we come up with that number. All right, for pitch selection, as I mentioned earlier, you have a couple of options. You can go for a lower pitch, like something around 0.9, for example. It's one of the sweet spots on the GE scanner. And generally, you need to couple that with a lower milliamperage. If you don't, you're going to be giving too high of a radiation dose. But if you can couple a slower table speed with a lower MA, then you generally will have a better data set because you're not moving the table so fast and you're not undersampling. When you undersample, you tend to get artifacts, particularly streak artifacts, which is a form of aliasing with CT. In our practice, we still use the 1.375 higher pitch with a higher MA, mostly because we like the shorter breath hold time, which is on the order of 4 to 5 seconds for the abdomen and pelvis alone. But both of those are reasonable options. As I mentioned, we generally start with a gantry rotation time of about 0.5 seconds, and we increase it a 0.1 second very carefully. See, I forgot my animation here. Make sure we do this. But I would caution you that, remember, every 0.1 second increment increases your dose by 20%. The other day I was looking at a prior and a current scan on an individual. The prior scan was a bit noisy but very diagnostic, and the new scanner was beautiful. And I thought, well, why is there such a disparity in dose? And one of the technologists chose the 0.5 and the other one chose the 1 second scan time. Basically, you double the radiation dose by going from a 0.5 to 1 second scan time, 100% increase. So be careful in making those subtle adjustments. All right, a few details about the abdomen and pelvis above and beyond just the abdomen. The protocol is pretty similar. We use the same injection parameters. We also use the same scan delay, but rather than just doing the abdomen, we extend the scan down into the pelvis. So it's just a longer acquisition, it's a slightly longer breath hold, and everything else is the same. So that's pretty simple. For a chest, abdomen, and pelvis, in the past, because the scanners were slower, I would basically do the abdomen and pelvis first, really focusing all the contrast media enhancement optimization on the liver itself. But the scanners are so fast now that we've changed our protocol, so we simply do the automated triggering, everything like we did for the abdomen and the abdomen and pelvis. We use a slightly shorter scan delay of about 35 seconds instead of 40 seconds, and then we basically do the chest, the abdomen, and pelvis sequentially in one breath hold from top to bottom. If the patient tends to breathe a little bit near the bottom, it's probably okay because there's not a lot of motion in the pelvis from diaphragmatic motion. So that's something that the patients can tolerate. All right, let's talk a little bit more about the automated tube current. There are two different types. There's Z-axis modulation, and this is measured from the scalp basically, and the scanner can determine how to change the milliamperage along the Z-axis as it goes from cephalocaudal direction. That's the Z-axis modulation, but there's also an option on many of the scanners to rotate, as you rotate the scanner around the patient, that there's also XY modulation. Most patients are narrow in the AP dimension than they are in the medial lateral dimension or the left-right dimension. So as a result of that, you'll have lower dose as you're projecting in the anterior-posterior direction than you will in the right to left or left to right direction. So it'll modulate both X and Y and Z, and that'll give you more of a radiation savings. I highly recommend that you use this routinely. How do they work? Well, it basically acquires an AP and lateral scout and looks at the attenuation along the patient in the z-axis and determines what the milliamperage will be over that particular time. As an operator, you specify the noise index in Hounsfield units. And that is very important that is specific to a certain slice thickness. I'll tell you a story about that. A few years ago, we decided we would redo all of our protocols. And we went to a higher noise index thinking we were ready for noisier images. And a few weeks later, the new images started coming out. And I looked at the images and I thought, wow, these are beautiful. We really are making an impact here. We really made some good choices. And then I looked at the dose page and realized that we actually had increased the radiation dose. And that was because although we had gone up in the noise index, they were using it on thicker slices. And actually, we were going up in the radiation dose, and that's why the images look less noisy. So I'm going to talk about that more, but it's important to specify the right slice thickness for that noise index. The other parameter that you have to select is the minimum and maximum MA. And generally, we pick a maximum MA that's basically going to peak out or max out during the pelvis, because we don't want to get too high in the pelvis because of the concerns of radiating the reproductive organs. So in general, that's how we select our maximum. Now, what do you get by doing automated tube current? You can see that this paper from Manu Kalra at MGH basically show that as you go up in the noise index, you can get anywhere from a 20 to 41% drop in radiation dose. You can see that the higher the noise index in Hounsfield units, the higher the radiation dose reduction. I would actually recommend that you start around 12 to 12.5 Hounsfield units if you're new to this, and then work your way up as you become more comfortable with noisier images. Because noisy images take a while to get used to, and that's true not only of noisy images, but also of the new reconstructed images using iterative processes. All right, there's another technique on the Siemens scanner called the automated tube voltage. And basically what it does is it acquires a AP and lateral scout radiograph as well, and then it figures out from that what the kilovoltage should be. It doesn't vary the kilovoltage along the z-axis like the MA does, but it does pick a kilovoltage that would be optimized to that patient, and then it uses the same kilovoltage from top to bottom. In this one study from European Journal of Radiology, you can see that 78% of the time, and for a chest CT, it shows 100 kVp, 22% 120 kVp, and that overall the mean drop in the dose length product was 22.8%, all the while there was excellent image quality. So it looks like an additional way of doing radiation dose savings, particularly in the chest where we use lower kVps. All right, now I'd like to turn our attention, because I get a lot of questions about iterative reconstruction. You know, what can I expect to do these? How should I implement them? What are the different types? And if you look at the history of reconstruction, the first generation was the filter back projection, which basically was done all from the raw data. It assumes a perfect model, and I'll show you what I mean by a perfect model in a minute. And there's a sinogram image there of the raw data. And basically, this has been what we've been doing since the inception of CT in the 1970s. Second generation is basically filters applied to the slices or the image space. You can get some noise and dose reduction slightly from doing that. They have different names from different manufacturers, as you can see. Third generation are those statistical-based iterative reconstructions that use a combination of both reconstruction or raw data and slice data. And generally, they model both the statistics in the photon and the electronic noise, and you can get more substantial drops in noise and dose. And this is referred to as ACER for GE, Sapphire for Siemens, and iDose for Philips. And they all have about similar image quality and dose reductions. And then the fourth generation is the full iterative reconstruction, where it uses raw data only. And this is basically it models the actual geometry of the entire X-ray beam, more substantial dose reductions, and with the options for a little higher spatial resolution and improved low contrast detectability. And this is referred to as MBIR, model-based iterative reconstruction, or VAO, from General Electric. So what do I mean by a perfect system? Well, here you can see that an ideal system would be one in which there's a pencil beam all the way from the focal spot to the detector. But unfortunately, it's not a point source at the level of the anode. It's not a pencil beam. Its interaction with the voxel in the patient is not point-like, and this interaction with the detector is not point-like either. Furthermore, if you assume a perfect noise model, that's an incorrect assumption. And as a result of that, although both the filter back projection and techniques that use both raw data and slice data, statistically like ACER and Sapphire, they do pretty well until you get to a very low radiation dose, and then there's just too much noise at that level to have good, adequately diagnostic quality images. So they're good to a point. So as I mentioned, iterative reconstruction uses using such as ACER, Sapphire, and iDose use a combination of raw and image data and looks at the statistics. Now, what I wouldn't recommend is that you just jump in these with both feet and go to 100% ACER, for example, because what you're going to find is these images look different than you're used to. It takes a while, maybe several weeks, for you to get used to the new look and feel. So start out by blending with filter back projection. And start out by doing not so generous blending. Use a 20% blending, maybe a 30%, and then inch your way up as you become more comfortable with the image quality. You can see that this 50% and 100% ACER, you're going to get more and more noise reduction, and it'll get better in terms, and you can get more dose reductions, but you're going to have a penalty pay in that the images are going to look different than what you're used to. And you may not be happy, and there may be a backlash. That's why I highly recommend that you go slowly on this. Now, what does blending mean? Well, here's an example of a 50% blending. You take all the data from the filter back projection, you add it to all the data from ACER, you divide by 2, and that's a 50% ACER blending. So it's a pretty simple process. And generally, what you'll see with these techniques is that you can see about a 30 to 40% drop in noise and radiation dose without significant change in artifacts or low contrast detectability. Those artifacts aren't going to get any better, neither will low contrast detectability. But as I mentioned, they have a different look and feel, and you have to get used to it. Now, if you want to go to a 50% dose, then it's basically you increase your noise index by 1.4. For example, if you're using 0.625 millimeter slices as your noise index, if you're using a 22.1, then you go to a 30.9 noise index, and that'll give you a 50% dose reduction. Notice the CTI is 28 and 15, showing about a 50% reduction. But notice that lower image on the right, it looks different than what you're used to, so be careful in doing that. Now, as I mentioned, the noise index is very importantly predicated on the slice thickness. The thinner slices generally have higher noise indices. And here's a nice table from Manny Canal's paper in 07. Notice that the noise index for 0.25 at various levels of doses are very high, very aggressive 40 Hounsfield unit is going to give you a relatively low dose, but I wouldn't start so aggressively. Start with a lower noise indices so that you don't have a backlash. So I would inch your ways up so that they're not too noisy to start out with, because you're not going to be happy with images that are either too noisy or have too much of that impressionistic or plastic feel that the iterative reconstructions have. So start carefully with those. And here again, maybe start with a 30% dose reduction by multiplying your noise index by 1.2 and inching your way up. Again, using the slice thickness that's most appropriate. Now, how does MBIR work? Well, basically what it does is that it models the entire system. It models the shape of the focal spot on the anode. It models the shape of the X-ray beam. It models the interaction of the X-ray beam with the voxel in 3 dimensions. And it models the interaction of the X-ray beam with the detector. Furthermore, it models the real noise. As a result of that, you get much better data, even from very low radiation dose data sets. The penalty to pay, however, is it takes longer to reconstruct these images because there's so much going on. I want to share with you some preliminary results from the multi-center study from VAO, where we basically took 24 patients who were scanned at 3 different sites, including here at Duke, at Massachusetts General Hospital, and at Froedtert in Milwaukee. And we looked at the upper abdomen in patients with known or suspected liver lesions, and we scanned them twice. Once with a standard of care ACER dose, and that's an ACER dose, not a filter back projection dose. And then second time with a 70% dose reduction with the goal of 1 to 3 millisieverts. It's an aggressive drop in radiation dose, but we wanted to see kind of as a standard how it would work. It's not suggesting you go that low. I'm suggesting this is the benchmark for comparison. In those 24 patients, we had a total of 144 reconstructions, including a filter back projection, an ACER at 50% blending, an MBIR or VAO, and every patient times 2 at both the standard of care ACER dose and the very low dose. So 6 reconstructions times 24 patients. We looked at both quantitative analysis in terms of noise, as well as qualitative analysis with 2 independent and blended reviewers per case, looking at specifically for liver lesions and at image quality. Here's the data for quantitative analysis in terms of standard deviation of the noise. Remember, our benchmark was the ACER dose. That's why I put the red dotted line there. And you can see that the very low dose for filter back projection ACER was quite a bit higher in terms of noise. Even the filter backs at the standard dose was higher. But both the standard of care and the very low dose had low noise with the MBIR at both acquisitions. Where you say, well, that sounds all good. What about diagnostic adequacy? And we scored them. Each reviewer said, all right, how does it compare to what I'm used to, with 4 being similar image quality to what I'm used to? 5 was and higher was worse, 3 and lower was better. And here you can see the data on that adequacy score. Again, 4 was what I'm used to, higher is worse, and lower is better. Notice that, again, our standard was the ACER dose standard of care, and that we had slightly worser adequacy scores for the model base at the very low dose, but not statistically significant different. Also notice that the standard of care was even better at the with the MBIR, and this is a suggestion of where to start. If you want to start with MBIR, I'd start with doses that are only slightly lower than you're used to, because I think that's probably a good way to get used to the difference in image quality. However, this isn't the whole story. When you break it up by the reviewer, it tells a very interesting story indeed. In that, notice that the 3 reviewers were quite disparate. There was one reviewer in particular who felt much less comfortable with the adequacy scores than the other 2 reviewers. And this is a reflection of reality. Not everyone's going to like these, and that's why it takes a while to get used to these different images. They look different, as I mentioned, and I wouldn't jump into them too hard. Give yourself a chance to get used to the difference in image quality and the different look and feel before going to too aggressive dose reductions. And then the last question we asked is, what about overall diagnostic quality score? 1 and 2 were either good, willing to read in all situations, or may actually have diagnostic advantages. 3, 4, and 5 were actually fair, poor, or terrible. And the data looks like this. Again, the lower the score, the better. Our ACER standard of care was again our reference point. The model-based IR at the very low dose was slightly higher, but not statistically significant. And again, the model-based at the standard of care did indeed look like it's a good place to start without actually lower diagnostic quality scores. But again, when you break it down by our reviewers, there was a disparity. Not only was there one reviewer that was particularly different, but notice there was actually a difference among all 3 reviewers at the standard of care. So again, reflects the importance of jumping into this slowly, if that's possible, and maybe jumping in or easing in is a better word. Here's some examples. Standard of care in the top row, very low dose in the bottom row. Notice how much noise there is in the filter back projection, even with the ACER at the very low dose. And although the noise is substantially reduced in the MBIR, you can tell that image does not look the same. They have a different look and feel. And that's why I wouldn't suggest a 70% dose reduction at the outset. And here's one more case with a bunch of liver lesions, again, showing the differences in image quality, not only in terms of noise, but also in terms of the look and feel. Notice that the model base of the standard of care has a nice look about it, and I would suggest that you maybe start at that level before inching the dose down. So our conclusions about the very low IR study, model-based IR image quality was acceptable even at low doses. And it was comparable to the standard of care ACER image quality with a 50% blend, but there was considerable reader variability reflecting comfort and experience with both low dose and with IR images, and that's a very important point. Now, I like to monitor the dose. I like to look at the dose page as often as I can, and I use this quick reference because I'm used to numbers in terms of millisieverts. Generally, we like things to be no more than 20 millisieverts, generally less than 10 millisieverts, but this gives me a ballpark of where we are. And the number that I like to remember is this one here because it's easy, because you can move the decimal place on the DLP over 2 places and multiply 1.5, and I can do that math in my head. For example, for a brain CT, you simply take the DLP, which is 193, you multiply by 0.0023, and that'll give you the dose in millisieverts, taking it from the dose page. And for an abdomen and pelvis, again, move the decimal over from 500 to 5, multiply by 1.5, that gives me 75 millisieverts, although technically you factor in the pelvis as a slightly different factor, and it's a little bit higher than that. But it's math that you can do in your head to kind of monitor how you're doing in your practice. Having said that, I want to share with you a study that we recently did where we looked at 12,000 patients scanned in the Duke system repeatedly. Every one patient was scanned at least twice in our system, and you can see the numbers here. We took patients that had similar protocols and more than once, including abdomen and pelvis, chest, abdomen, and pelvis, a renal stone protocol, and a chest CT. And you can see, particularly in the column on the right, this is the mean ratio of the highest dose to lower dose in any one patient. So notice that, for example, for a renal stone protocol and a chest CT, the mean variation from the max to the min was 2.0. That means that that's twice the radiation dose in the same patient. That was as much variability. These are very sobering numbers, and you know, it takes data like this to be retrospective and introspective, and to look at your data and say, hey, you know, we need to do something better to try to improve our variability or our reproducibility. So it's very sobering. All right, a little bit about the dual liver. We use this again, as I mentioned, for hypervascular liver tumors, as well as hypervascular metastases, particularly from endocrine tumors. The protocol goes like that. We start with an injection, and then that's typically at a little higher rate on the order of 4 to 5 mL per second. Again, the dose is customized, as we talked about earlier. And then for arterially enhanced studies, we follow with a saline chaser, which is typically about 50 mL. It takes about that much volume to flesh out the veins in the arm. And we give that at a higher rate than we give the saline, give the contrast media, typically 1.5 to 2 times. And you may say, well, man, that seems like an awfully fast rate to give saline if I'm giving contrast at 4 mL per second. Well, remember, saline is a very, very low viscosity relative to contrast media, so it's not that challenging to give saline at 8 to even 10 mL per second if you need to. But that'll flush it out a little bit quicker. Then we monitor, again, the aorta. Here you can see we monitor the aorta or the spleen. I'll show you that data. Generally use a 100 household unit threshold. And then we start a few seconds later. We do the arterial phase, and then we do the venous phase 40 seconds after the end of the arterial phase. And the parameters for the MDCT are basically the same as we talked about for an abdomen and pelvis. Now, for the dose and rate of contrast material for arterial enhancement is different than venous enhancement. The timing of the enhancement is determined by how fast we give the rate of iodine delivery, and then that'll figure out when we scan. So, for example, for the aortic enhancement, if you give contrast at 3 mL per second, you may get an aortic enhancement profile that looks like this. If you increase the rate to 5 mL per second, you can see you'll basically get something where aortic enhancement is a little bit higher and a little bit earlier. So again, this is different than the venous system where it's predicated more on the dose. This really has more to do with the rate of delivery, not the dose of delivery. But if you include a venous phase, you need to factor that in. I think it probably makes more sense that we're moving towards away from using aorta for triggering to using the spleen, because it's a lot closer to the liver. And we have two patients that we compared, both splenic parenchymal enhancement as well as descending thoracic aorta. And basically what we found was that if you look at the delay, it was a little longer using the spleen on the average. We had a slightly higher liver parenchymal enhancement. We had slightly higher portal venous enhancement, and we had slightly higher hepatic venous enhancement. So I think probably our delay was a little bit too long. But in general, for qualitative scores, most of the reviewers gave higher qualitative scores to those that were triggered from the spleen than the aorta. So it suggests that it's probably a better way to do things. All right, so again, what we're looking for aortic enhancement of the arterial phase of the liver is minimal parenchymal enhancement, vivid arterial enhancement, some early portal venous enhancement, no hepatic venous enhancement, and then hopefully we'll see hypervascular tumor enhancement as in this patient. So what I really wanted to finish up with is that I spoke about the importance of doing a little self-reflection by looking at how much our radiation doses varied from patient to patient. And I'm really excited about the opportunity to do that with the power injectors as well. And new software is coming out which will give us a lot more details about the injection parameters. And this particular software, which is referred to as Nexo, we're beginning to get familiar with it here at Duke. And this is one of the screenshots. And here's a patient that has a radiograph through the arm showing the contrast media extravasation. If you break down the sheet, you can see that there's some demographic data about the patient themselves, which comes from the hospital information system. There's some data about the procedure, including the lot number, which I think is interesting. A little bit about, well, how much contrast media was injected, et cetera. But more interestingly, it actually tells you what was programmed in this case, 90 mLs at 4 mLs per second, and then 20 mLs at 4 mLs per second of saline. But it shows what actually was administered in this case, where there was a contrast media extravasation. So only 34 mLs went in. The injection rate was actually 3.8 mLs per second, and there was no saline. It does indicate that the EDA did fire and did detect the extravasation. And this is something that I like a lot, and it's this pressure graph that shows me exactly what happened during the injection. Notice that the pressure suddenly dropped off as the extravasation occurred. So it occurred, and then the EDA triggered it about here a few seconds later. You don't want it to occur initially because it might trigger on subclinical extravasations. And then I really like this flow graph as well, because although we specify so many mLs at so many mLs per second, we really don't know exactly what happened. We look at the images and sometimes some things don't look right, and we say, hey, I wonder if the contrast media injection went well. Sometimes it didn't, and there's a note saying it didn't, but sometimes there's not. So this will be very helpful for us to know exactly what happened during the contrast media injection. I think this technique will allow us to self-examine to see how well we're doing, to see where we can make changes to improve our practice. It may allow us to reduce doses in some patients. It may suggest that we increase doses in other patients. But overall, it's a very exciting technology that allows us to do a better job at what we're doing. Here's the phase graph. And also, there's an opportunity to do mining of the data. Here's a sheet that allows us to look at a couple of years of data. As you specify, you can look at different months. You can look at adults versus children. You can look at different patients with different sizes. And then you can break down your practice by different exams and see how you're doing in utilization over time in terms of trends. So I think all these opportunities to gather data about our practice allow us to do a better job, and in the end, we improve our practice. So, Kristen, that includes my remarks.
Thank you so much, Dr. Nelson. That was a very engaging presentation. And now I'd like to open the floor to our panel discussion. And we already have a few questions in. let's start with this one. What is your policy on wait times between readministration of contrast to the same patient for IV contrast studies on the same day?
So that would really have to do with how much contrast media they received. So in the old days, we used to give 60 grams of iodine routinely for certain liver applications. So I kind of keep that number in mind. I don't really like to give more than 60 grams of iodine to one patient in any one day. So typically we use in the order of 40 to 45 grams in our routine patients. If you're using a smaller dose, then you might have the opportunity to give a little bit more the second time. That's in terms of the dose. In terms of timing, I don't know that it's a whole lot different if they're an hour apart versus 2 hours apart. I suspect that the half-life of the contrast media is pretty quick, so waiting an hour or two probably gets most of the contrast out of the system within that time period, so that's probably adequate for most applications.
Okay, thank you. And some more questions. What is your experience with the American College of Radiology as far as what is their stance on noise versus dose in your data?
So I'm not sure I understand the question. The American College does have guidelines, but they're not very explicit guidelines, in my opinion. They're more guidelines on what to do. I really think that the best thing to do is to make sure that you're comfortable, first of all, with the image quality in terms of the noise. If you feel like you're comfortable with the image quality, then I would experiment with going up in the noise index a little bit to see if you can tolerate a little bit more noise. I know that we, in our practice, and there's 13 in our group, have gotten much more comfortable with noisier images now than we were 5 years ago. And if you look at that data that I suggested with 12,000 patients, we really have seen a substantial drop in dose, particularly in the last 2 or 3 years. The worst thing you can do is do a data set that's too noisy. Because if you have a non-diagnostic scan, you basically gave radiation that was of no value at all, and that's even worse. So I would recommend, again, very minor changes and kind of evolutionary changes in your noise indices to get more comfortable with the noise index. But above and beyond that, I don't think the ACR has specified noise indices, nor have they given the certain noise levels that we should tolerate.
And the next one, do you require a EGFR on all patients prior to contrast administration or just a subgroup?
We have a pretty low threshold to get an EGFR on our patients, and we measure the serum creatinine on almost all the patients. We do have criteria. Everyone over the age of 60 automatically gets that either before they come for their clinic appointment and their CT scan, or we do it in the department using this iStat device that can give it to us in a few minutes. Younger patients, and we don't typically require that. Obviously, if they're younger and they're diabetics or they have hypertension or they have heart disease or other comorbidities, and we routinely get creatinine in those patients as well and calculate an EGFR.
Okay. And can decreasing the slice thickness increase the dose and decrease the noise index?
So first of all, aside from the noise index, if you want to go to a thinner slice and you want the same image quality, then fundamentally you have to go up in your radiation dose to get the same noise with a thinner slice. If you're comfortable going to a thinner slice and going to a higher noise level, then you will have less of an increase in radiation dose by going to a thinner slice. So yeah, we do reconstruct images at 0.625 millimeter thick slices at 0.625 millimeter increments, but we don't read those routinely. Most of us like to read images that are on the order of 2.5 millimeters to 5 millimeters thick for routine images. It's not just the noise that we get an advantage by going to thicker slices for reconstruction reads, but it's also the number of slices. It's just more challenging to read through that sheer number of slices. So you get the noise down by reconstructing with a thicker slice and then the isotropically acquired voxels.
And can you comment on how you pick and choose saline chaser volume and rate, and how that changes image quality, contrast distribution, scan time, etc.?
So basically, as I mentioned, we use a 50 ml volume, and we did experiments in phantoms where we did 25, 50, 75, and 100, and basically the effect peaked out at 50, and that's why we chose that number. And then we gave the saline at a wide variety of different rates compared to the iodine dose, and generally, if you give it at a higher injection rate than the contrast media, then you'll get more enhancement. Like I said, if you go up to 1.5 times, that's a comfortable rate for most individuals. So if you're giving the contrast media at 3 to 4 mLs per second, then I would give the saline at 4.5 to maybe even 6 mLs per second, and because it's a lower viscosity. However, what do you get from doing that? If you're imaging only in the venous phase, you really get nothing from doing that because it's not really, the effect of giving it quicker is really dampened by imaging in the venous phase. If, however, you're imaging in the arterial phase, either alone or in combination with the venous phase, giving a saline chaser at its optimum will give you about an additional 10 household units of enhancement in the aorta. So it's not going to give you a lot more enhancement, but it will give you a little bit more. One of the strategies is actually to go to a lower iodine dose with a saline chaser to give you the same amount of enhancement. That's also another strategy.
And Dr. Nelson, we're at the top of the hour, but could we take a few more minutes to answer some questions that just came in?
Sure.
Okay, great. Thank you. Could you describe how contrast injection details are currently documented at your hospital?
Sure. We're moving away from paper, but at the current time, we have our technologists and nurses fill out a contrast sheet, which includes a lot of historical information, includes demographic information about the patient. It includes the date and the level of their most recent serum creatinine and their eGFR. And then it also includes how much volume we gave, at what rate, whether or not we used the extravasation detection apparatus, and whether there was any problems. We also list the site of the IV and the angiocath type that was used.
And follow up to that, do you believe more accurately documenting contrast delivery parameters will result in changes to contrast protocols?
I think it will. It's kind of like our radiation dose experiment, where the more we know about our practice, the better we can do at making adjustments in our practice. I think we probably can be more efficient. In some cases, we actually may see a dose savings, and some patients may actually need more contrast media. But I think we'll learn a lot about our practice by monitoring how we're doing. Right,
and that goes into a follow-up question. I think you kind of answered it. Do you believe patient-specific contrast dosing benefit from more accurate contrast delivery records?
Yeah, I think one of the things that you're alluding to, I think, Kristen, is that if we have the opportunity to look at the contrast media dose and rate on when the patient was scanned previously and look at their level of enhancement, we might be able to make adjustments. I think we're not quite there yet, but I think that the monitoring and the ability to look historically at what we've done, along with image quality, will allow us to make some very interesting enhancements to give provide images that are more higher quality and more efficacy. So I definitely think it's going to make an impact on what we do.
Just a couple more questions. What is your stance on IV hydration for patients with poor renal function?
So I think IV hydration is probably, there's not a lot of data on it, but I think it is effective. I think it's easy to do. If you go to the literature, there's lots of different protocols for doing it. Some people say giving up to a liter. I think generally what's thought is that it's probably worthwhile to hydrate the patient before the scan as well as after. If you have the option of doing it only once, I would do it after rather than before. And you might actually give them a liter over an hour or so. That's a conservative way of giving it. And there's not a lot of data to support that particular protocol, but it is a strategy that many have used because there's really not a lot of data out there, even though I think it's probably one of the more effective ways to minimize contrast-induced nephropathy.
In what situation do you prefer to use barium as oral contrast?
I don't really care that much from a diagnostic standpoint or from an efficacy standpoint, but the patients tend to prefer the dilute barium preparations over the dilute gastrografin because it tastes a little bit better. It's a little bit more palatable. But in general, doesn't really matter to me. If you have a patient that's allergic to iodine, in general, philosophically, it's better to give dilute barium, although most patients that are allergic to iodine get so little absorption of the intraluminal iodine and gastrografin because it's so dilute that they won't have an allergic reaction from that. But in general, we have a pretty low threshold to use dilute barium.
Okay. And finally, instead of increasing the amount of contrast delivered, could you use a high osmolar agent?
We like to use the high osmolar agent for scans that are arterially enhanced because it gives us the opportunity of basically introducing more iodine into the arterial system quickly since it's more concentrated per unit volume. So in general, for dual livers or dual pancreases or for aortic studies, we prefer 370 over 300 or 350 because you can get more iodine in there. Keep in mind, however, that the more concentrated agents are also much more viscous. 370 has twice the viscosity of 300. So in that case, the saline chaser may be even more advantageous because it may languish in the venous system because of its weight. So it's nice to be able to give it and then flush it out of the arterial system with a saline chaser, which works really well for arterially enhanced studies.
Well, thank you so much, Dr. Nelson. This has been a fantastic discussion, but we do have to come to a close. And thank you very much for your participation today.
You're welcome. Thank you.